Hello, everybody. Welcome to the Kickstart series. I'm Dr. Meenakshi, one of the mentors at StudyMEDIC. So today's discussion is going to be regarding labor ward prioritization, which is an extremely important topic for MRCOG Part 3. So yeah, as we always begin with a quote, dream big and work hard and make it happen. So how do you go about labor ward prioritization? It is actually very simple. It appears to be a bit difficult, but it is not actually. So always, whenever the labor ward is given, you could have either 6 cases, 8 cases, or it can go even up to 10 cases. So make sure that within the given time frame, you read all the tasks first, and we need to categorize the case based on the urgency, like whether the case is urgent or whether it's semi-urgent or whether it's routine case. We need to have a background idea about it. And once you categorize this in your mind, make sure that whenever you go to the examiner, you first talk about the urgent room which is given. So during this session, of course, you all will be getting an idea about how we're going to do this. And there would be certain tricky points which are given, like they could be something like RH negative pregnancy or Jehovah Witness. Sometimes they could give a case of PPH, but they would give like Jehovah Witness. Probably we can go towards the first thing that comes to our mind could be like maybe we can do a blood transfusion. But the key point here is Jehovah. So we need to pick up certain kind of hints like that. And we need to be aware about who is in our team. And not every room and every case would be taken by us. We need to assign work to each and everyone who is in the team. And sometimes the tasks could be evolving as well. Like probably they could keep adding blood pressures or whatever the findings. We need to ask the examiner, or probably even the examiner keeps on adding. You will go, as we move through this discussion, I'm sure you all will be getting an idea about what is all this. But whenever you're going, make sure that you assign work. Each and every room, we need to assign like whether the ST3 is going to take care or whether it's you who's going to take care, or whether it's the midwife. And please always mention whether it's an urgent case or whether it's a routine case. That is very, very important. So today we'll take up one task, and I also have Dr. Soumya ma'am with me here who's going to help me today. Hello, ma'am.
Hi, Meenakshi. Hi, good morning. Yes,
Morning,
thank you for actually choosing this task. As you rightly said, this is a task which we generally deal every other day, but probably there are a couple of things which have to be taken care. It could be lengthy scenarios, so we need to make sure that it is done on time. As you rightly said, right now the trend is to make sure that they keep giving you the scenarios. Okay, dear, you can, there is one more slide, I believe. So we'll show that and we can start with the timer. Okay. Yeah.
Yes, ma'am.
Okay, if you are, once you are ready, you can start.
Yes, ma'am. Ma'am, we'll start.
Yeah, sure. I've kept the timer, please.
Yes. Hello, I'm the ST5, taking the labor room handover at 8 a.m. with my efficient team, keeping the patient's safety as my topmost priority. I hereby begin my labor ward prioritization. So my first urgent room is going to be room number 2, who is a multi-para at 38 weeks of gestation, who's been given a VBAC trial. May I know her findings?
Yes, she is having good contractions, around 3 to 4 contractions in 10 minutes, but she's complaining of scar pain. And on examination, there is a scar tenderness, pulse is 110 beats per minute, 4 centimeters dilated, membranes intact, but the midwife is unable to feel the baby's presenting part. Okay, and also CTG prolonged variable decelerations are noted.
Okay, so hereby, because based on the findings which are given, I suspect a uterine rupture. So since my consultant is busy in the emergency OT, I would like to ensure who is the second consultant on call. I would like to inform the anesthetist as well as the neonatologist and keep the OT team ready and shift the patient to the category 1 cesarean section once I debrief their attendants regarding her condition. So my next priority is going to be room number 4, who is a primary gravida at 34 weeks of gestation, who's had a PEEP from, and the patient is not feeling well. May I know her findings?
Yes. So actually, she's having leaking since 20 hours. But right now she is having temperature, like she feels unwell, and the pulse is around 110 beats per minute, blood pressure 90/60, temperature is 39, and respiratory rate is 22 per minute. Uterus is tender. There is a fetal tachycardia, and the speculum examination, it is 2 centimeters dilated, but there is a foul smelling liquor noted, and CTG shows tachycardia.
So this is a case of chorioamnionitis based on the findings. So firstly, I would like to initiate the sepsis 6 bundle protocol, inform the consultant as well as the neonatologist. Since this is a preterm case, I would like to ensure whether there is a bed availability in the NICU or not. And then I would inform my consultant, take the opinion. Since it is a preterm case, we'd like to cover the antenatal corticosteroids to enhance the lung maturity. Plus, the patient's pregnancy needs to be terminated, should be taken up for an emergency cesarean section. And then we can go room-wise. So the first room is a 25-year-old primigravida who is post-dated pregnancy awaiting induction of labor. As I keep settling my emergency room, I would want to send my junior and ST3 to go and talk about to take an adequate history, review all her antenatal records until date, review all whether her reports have been up to date or not, do an abdominal examination as well as the per vaginal examination to check for the Bishop's score and assess the need for induction. And the method of induction can be decided based on that. And once my urgent rooms have settled, I shall go and review the case by myself. And then there is room number 3, who is a multigravida at 40 weeks, and she's in second stage of labor, and she's tired, pushing for 1 hour. So may I know the findings, PV findings?
Yes. She is fully dilated, actually fully dilated and pushing for last 1 hour. And she's not on any analgesia. It's left occipital anterior, +2, mild caput, and no molding noted. CTG is fine.
Okay, so because the CTG is normal here and she's been tried for 1 hour and the position is also favorable, it is at +2 left occipital anterior. We can discuss with her regarding the benefits as well as the risk of operative vaginal delivery, and we shall proceed after involving the consultant as well as senior consultant and a senior midwife. And the next one is room number 5, who has just delivered vaginally 30 minutes back, and she's a known case of von Willebrand's disease. So may I know the amount of bleed until now?
Actually, the midwife is not worried about the quantified blood loss because it's only 150 ml. But this was a spontaneous vaginal delivery, but there is a trickling, ongoing trickling, which is happening. But the uterus is well contracted.
Okay, so since the uterus is well contracted, I would want to do a vaginal examination to see if there is any minimal tears or anything from where the trickling is happening. And once it's been settled, I would want to involve the hematologist in terms of managing the von Willebrand's disease. The next is room number 6, who was delivered by full term by operative vaginal delivery 3 hours ago. And she's a known case of gestational diabetes, and the baby is in NICU. So since she was delivered 3 hours ago, I would like to go and check about the general condition, her observations. Is there any PV bleed, and whether she's able to take orals, whether she has passed urine or not. And I would like to know about her sugar levels as well postnatally. And then I would want to inquire about why the baby is in NICU. May I know?
The thing is, her blood sugars are well controlled and she was on insulin, but the baby had hypoglycemia. So for that further monitoring, they have shifted her to the, NICU. The baby has been shifted to the NICU.
Okay, once my urgent rooms have settled, I shall talk to the pediatrician regarding the baby and know about the condition of the baby. And the next is room number 7, who is a multigravida, and she's at 39 weeks of gestation, who has come with decreased fetal movements, and the midwife is unable to record the FHS on the Doppler. So I would like to do a bedside ultrasound to confirm the fetal heart rate.
Yeah, the ultrasound confirms IUFT.
Okay, so since this is a full-term IUFT, empathy is required in managing the case. I would want to review her antenatal records to see if there is any risk factor for this IUFT, and empathize and debrief her regarding the condition, what has happened, and regarding the mode of delivery shall be explained to the patient. And then is room number 8, who is a multigravida, and she's at 12 weeks, who is waiting for cervical cerclage, and she has had a history of incompetence. So firstly, I would want to send my ST4 to go and inquire about her antenatal history, whether all her reports until now are update or not, whether her booking scan has been done, her dating scan has been done, What about her investigations? I would like to know. And once my urgent rooms have settled, I shall apologize for the delay and I shall counsel her regarding the cervical cerclage procedure. And next is room number 9, who is a primee with 38 weeks of gestation, and she has presented in labor, and she's a known case of gestational hypertension. May I know her blood pressure?
Okay, so actually the midwife is little concerned because this patient is complaining of headache, which is occipitofrontal, and her blood pressure is 170 by 110, urine is 2 plus, and clonus is noted on examination, but the baby's fetal heartbeat seems to be normal, CTG is normal, but the midwife is worried about the symptoms.
So this is a term case with impending eclampsia. So firstly, I would want to inform my consultant regarding the same. And then the patient needs to be treated with IV antihypertensives as well as IV magnesium sulfate in order to prevent eclampsia. And the pregnancy needs to be terminated. Based on her perabdominal and pervaginal findings, we shall terminate the case. And next is room number 10, who is a primee at 28. She was delivered yesterday by LSCS in view of antepartum hemorrhage, and the case is now in HDO. So may I know her observations?
Okay, the observations are stable. She had yesterday had a massive antepartum and the postpartum hemorrhage for which she has received like around 4 blood transfusions, FFPs as well. But right now she is stable and the observation seems to be fine. And the recent hemoglobin is 10 gram%.
Okay, so since the patient is stable, it just requires the regular monitoring which needs to be done. And we also need to check about the baby, how is the baby doing, and the general condition of her also needs to be monitored. And once she seems to be stable for next couple of hours, then she can be shifted from the HDU. So that would be my labor ward prioritization.
Okay, so if you wish to add anything, because a few seconds, yeah. Okay. So yes, let me give my quick feedback. Meenakshi, it was wonderfully done, but couple of things, okay? Like I would suggest when you start off, okay, it's always a structured discussions, which I always mention. You have to first mention, I'm Meenakshi, one of the exam candidates. I've gone through the scenario. I'm happy to start the discussion rather than telling I'm ST5. Good that you did this so that it is easier for me to explain, because for all the practical purpose is a structured discussion. So you need to introduce and later on you tell whomever you have. Okay. Couple of things which I think we can, you covered most of the things very well. Second room, I had no problem. Yeah. Couple of rooms, you didn't bother to ask me the findings. Okay. So for example, awaiting IOL, you assumed it as a low risk pregnancy. So probably because you have prepared the task, you know things, but in the real exam, it won't be like that. So it has to be uniform that you have to ask everybody. And here also, for example, room 6, you went on so many things and again you asked findings. So it's a good idea to summarize and ask findings and go on. And better avoid the word termination because you use twice. For example, in the case of this one, gestational hypertension, you would only talk about delivery. Terminations is for, like the babies which are not there. So this is a live pregnancies. So you instead of terminations, you can use delivery. Okay. And once in the beginning also, once you introduce yourself, I mean, actually one of the exam candidates, happy to start the discussion, give a gap of 30 seconds so the examiner can speak. Okay. Otherwise it was wonderful. Okay. Yes. Now we can brief about the station. Yeah. Yeah. What do you think? Like, what was your feedback? Because you have covered most of the things. If you want to add on anything, because that's how a reflection of you as a candidate. Yeah.
Yes, ma'am. I forgot asking findings, like in few cases. I think I was just rushing because I was probably thinking that I'm going out of time. So, yeah, in the first room, I
And
was
on
assuming
every
it as
room,
a
you have to
low
tell
risk.
whom you are setting. Okay, some of the rules which you missed because the mark is based on that.
Yes,
Okay, yeah.
yes.
Go on, please. Yeah.
So the first room was a post-dated case who was awaiting induction of labor. So an ST3 can be sent initially because this is a routine case. So the case needs to be assessed and the previous all our antenatal records, reports, everything needs to be reviewed and a per-abdominal pervaginal examination to assess the Bishop's score. And once we are finished settling with the other rooms, we could go and just apologize to the patient for the delay, and we can discuss regarding what are the benefits of induction of labor, what if it fails, and how long we are going to wait, and everything can be counseled to the patient once your urgent rooms are settled. So the second room was a previous car and labor. So this is an urgent case, and we need to review it. And among the list which was given, this was of top priority. So the consultant, the anesthetist, and the pediatrician needs to be involved. We need to inform them. And category 1 LSCS, once you debrief to the patient, and we can start off the case until the consultant arrives.
You can mention laparotomy because you're suspecting rupture uterus. Okay?
Yes, yes.
Okay.
Yes, ma'am. And the third room was the multigravida. And she's been exhausted since 1 hour. She's pushing since 1 hour and she's fully dilated. So until your urgent room settles, she can be reviewed by a midwife. You can send your midwife. And as the findings were left occipito anterior and it was at +2, it was very favorable and an indication for assisted vaginal delivery. Therefore, we can discuss her regarding the pros and cons of it, and then we can proceed with it. And the fourth room was preterm premature rupture of membranes, and the patient is not well. So as per the findings which were given, the patient was in sepsis. She was having tachycardia, hypotension, and the patient was having increased respiratory rate, tachypnea and all. So the uterus was also tender, and the PV findings also was the foul-smelling discharge. So this is a clear-cut sepsis case, a chorioamnionitis. So we need to initiate the sepsis 6 bundle, and then we can deliver the case. And then the fifth room was the known case of von Willebrand's disease. So since this is a bleeding disorder, sometimes they could also give you, and this could also be converted into a PPH case as well. For this case scenario, she just had a trickling, but sometimes it could be turned into a PPH as well. So such kind of tricky words needs to be picked up. So once your rooms are, once you're busy with your urgent room, just send your ST3 or ST4 to assess the blood loss, and based on that, we can move in accordingly. And of course, she's von Willebrand, so therefore we'll have to be taking the help of hematologists for monitoring of the levels and all postnatally. So the next room number 6 was a after delivery. She's a case of GDM. So we need to just check her observations, her urine output, whether the antibiotics have been given, what about her fluid monitoring, and her blood sugars. In this case, she was on insulin and her blood sugars are controlled, but the baby was having hypoglycemia, because of which the baby was admitted. So next is a room number 7, which is a full-term IUFD. We need to confirm it by the ultrasound. If the Doppler is unable to pick up, we don't take it as IUFD. The confirmatory is definitely an ultrasound. So once this is done, we need to counsel her regarding how we are going to manage the case, and then the further management and what our investigations needs to be done and all. And we need to find out like how, like what has happened, what could be the reason for it. We need to review her records as well, if we could get any kind of hint. And the room number 8 was a routine case, which was 12-week case with a history of incompetence. So I think here I forgot to ask details for this case, ma'am.
Yeah. So that it should be routine. There could be things, there need not be things. That's the reason you finished early. Otherwise, you wouldn't have finished, because the examiner has to speak. All right?
Yes. Yes, ma'am. So next was room number 9, and she's a term case, and she presented in labor with gestational hypertension. So it is important we ask for her blood pressure. And here she was with impending eclampsia. So therefore, we need to deliver the case immediately once we discuss with the consultant. And the next one is a post-operative case. It is a routine case. It was because of antepartum hemorrhage, the case was delivered by LSCS, and then she had a PPH as well. But now she's doing well. That is the reason, because of hemorrhage, she was admitted in HDU, but now she's doing well. And then we can check about the lactation as well. So that was regarding the labor ward prioritization.
Yeah, perfect. Thank you, dear. And there could be I would still go on, because it's okay if you went for 2 and 4 because it was very clearly given, but not necessary that they would even give that. Okay, in those cases, it's always good to go room wise. But I think because you saw something unwell, it's okay to go ahead. Okay, thank you, Meenakshi. Yes. Thank you so much. Thank you and well done. Thank you.
Thank you, ma'am. Thank you.
Thank you. Take care. Bye-bye.
Bye, ma'am. Bye.
And guys, whoever has not subscribed the channel, please do subscribe without fail. Okay. Yes. Thank you.